since past 1 week, pain in throat since past 1 week, and abdominal discomfort since yesterday. Patient was apparently all right a week back when he had fever, 100-degree Fahrenheit by digital thermometer, continuous in nature, not associated with chills, rigor, or night sweats, and relieved by medication. Patient also complains of pain in throat since past 1 week with painful swallowing and drinking, not relieved by medication, and has been increasing gradually over 1 week. The patient went to a local doctor 5 days back where he was given a 5-day course of tablet AZ and paracetamol, which did not relieve his complaint. The patient developed abdominal discomfort and heaviness, which he says is in left upper quadrant since past 1 day and is not associated with pain. There is no history of vomiting, diarrhea, constipation, altered bowel habits, blackening of stool, clay color or sticky stools. There's no history of regurgitation of food, loss of appetite, or weight loss.
Wait.
There's
To summarize the Krishna, just wait. Your patient's chief complaints are just fever with chills in 7 days, right?
Yep. And pain
And
in throat. No,
pain.
ma'am. Pain in throat and abdominal discomfort since 1 day.
Since 1 day. Okay.
Yeah, and it is localized in left upper quadrant.
Okay. So you need to mention that. Where is the pain, basically? Okay.
No, ma'am. There is no pain in the abdomen. There is abdominal discomfort.
Okay. There is no dragging sensation, nothing.
No, heaviness and abdominal discomfort is what he describes.
Okay.
There is no history of vomiting, diarrhea, constipation, altered bowel habits, blackening of stools, clay or sticky stools. There is no history of intake of any street food. There is no history of regurgitation of food, loss of appetite, or weight
Now
loss.
tell me, why are you giving me all this history? History of regurgitation, history of diarrhea, constipation. You have a patient who has come with history of fever and throat pain and left-sided pain. So what things that come to your mind first, and you want to rule out those things first?
Ma'am, a patient coming in pain of throat is usually a patient of tonsillitis or pharyngitis. So, and with left upper quadrant pain, I will think of either spleen involvement or involvement of flexure, splenic flexure, or stomach involvement. It can also be a case of hernia, that is diaphragmatic hernia or epigastric hernia, that can lead to pain localized to that area. If the left lobe of liver is involved, even that can lead to pain in left upper quadrant or heaviness or discomfort in left upper quadrant.
No, but considering your history, this patient has fever and then this pain. So what are the first things that come to your mind, and you will try to rule out those things first? See, one, it could be spleen. Second, which other organ comes into that area?
Colonic flexure.
Nothing else. Lower down.
The tail of pancreas.
No. When you're doing any abdominal examination, we always want to rule out whether it is this organ or that organ.
Kidney?
Yes. So you will in fact try to rule out whether this patient has any history suggestive of pyelonephritis. Okay, he has fever, he has a pain on the left hypochondriac, maybe it may be a lumbar region. Okay.
Right.
Your history of constipation, clay colored stool, and all that is not that so important. Okay. You said this patient has what type of fever? You have not described the onset, duration, progress of the fever properly.
Okay, ma'am. I'll repeat the history. Is that okay?
See, after your chief complaints, you should describe your chief complaints and then you should go to negative history. Okay.
Yeah,
so what kind of fever it is? Since when? So what is, tell me more about the fever.
Ma'am, it started 1 week back. He had measured it with the digital thermometers. It was 100-degree Fahrenheit. It was continuous in nature. It was not associated with chills, rigor, or night sweat, and relieved by medication.
Okay.
There was no sudden
Why do you
spike
call
or
it
increase
as a
in fever.
continuous fever?
Sorry, ma'am.
Why do you call it continuous fever?
Because there was no spikes, or there was the fever never touched the baseline and then it increased. So it was throughout the day, it was maintained at 100-degree
What is
Fahrenheit.
the difference between remittent fever and continuous fever?
Ma'am, remittent fever has diurnal variation with no dipping to normal. It does
Don't
not
say
touch
diurnal
the,
variation. What you're supposed to say, remittent fever, the fluctuation in the temperature is more than 1 degree Celsius, but it never touches the normal. Okay?
yeah.
And in continuous fever, the fluctuation in the temperature is less than 1 degree Celsius. Okay, that is the difference. While in intermittent, it always touches the normal. Okay, so your patient has continuous fever. So what are the differentials that you will keep in mind whenever any patient says he has continuous fever?
Ma'am, any systemic infection like HBV, viral infections, of course, influenza virus, HBV infection, HCV infection, hepatitis A, or
Hepatitis
bacterial
A
infection
never
like.
comes with so much of fever. Okay.
Okay, ma'am.
See, you are giving me some clue. Like it can be pyelonephritis, infective endocarditis. These are the two important conditions. Urinary tract infections, basically pylon. They come with continuous. They have continuous fever. Okay.
Ma'am.
ठीक है. ठीक है.
Yeah, ma'am.
Go ahead. What is pale Epstein fever?
Ma'am, it is seen in Hodgkin's lymphoma. There is cyclical increase and then there is fall over 1 or 2 weeks.
Okay. What is that? I mean, it takes so many days to rise, so many days to static, and then it comes down. What is it? Do you remember? Some of you, 9 days to rise, 9 days it remains same, and 9 days it comes down. What is typical history of fever or and associated symptoms if it is a Hodgkin's lymphoma or any other malignancy?
I'm not sure, ma'am. I didn't get your
No,
question.
you mentioned in your negative history. You are not able to recollect. You said something. Patient has a left hypochondriac pain. He has fever. And two other important symptoms, if you add, that will go in favor of malignancy or lymphoma.
Night sweats
Night
and
sweats
weight loss.
and weight loss, generalized weakness. So history of night sweats, generalized weakness, and weight loss goes in favor of lymphoma or any malignancy or lymphoreticular malignancy. ठीक है? Okay.
Right.
So that was about history of fever. What was your other chief complaint?
Pain in throat.
Pain in throat. Is there any relation to your to pain in throat and this left-sided heaviness or fullness that you are describing, or these are two different symptoms?
Ma'am, should I tell you out of the context or?
Okay. No, you just when you took a history, did you feel these are related or these are unrelated things?
Ma'am, it can be related as well.
Like what?
I mean,
what is
fever, infectious mononucleosis case.
Okay, infectious.
Usually, also dengue also comes with some abdominal discomfort.
Comes with sore throat, but dengue does have hematological manifestation, but getting splenomegaly and sore throat is only infectious mononucleosis. Patients can have sore throat and splenomegaly. It is usually acute. ठीक है, go ahead. So.
Ma'am, should I continue from where I stopped?
Continue with your negative, whatever history you are telling me.
There is no pain in micturition or red color urine. There is no history of cough, chest pain, hepatitis, previous recurrent upper respiratory tract infection or breathlessness. no history of rash, itching, yellowish discoloration of skin or sclera. There's no history of periorbital perinasal pain, ear ache or secretion from ear. There's no history of
Periorbital or
nasal
perinasal.
sinuses.
What you said?
Pain.
Pain.
Tenderness.
Why did you ask that?
Ma'am, influenza viruses or any infection can cause to lead to sinusitis.
That you will not describe, you know.
Ma'am, there's negative history for complications and
Okay, what history you have asked in complications?
periorbital perinasal pain, ear ache or secretion from ear, because he has
Otitis media. At the most, one of the complication of your upper respiratory tract infection is otitis media. Okay, go ahead.
The patient has had multiple relationships in past 2 months with multiple partners.
Okay.
The bowel and bladder habits are normal. Sleep-wake cycle is normal.
So you think he is a high-risk patient who may have he is exposed to sexually transmitted diseases, right?
Ma'am, the patient said he has relationship in only past 2 months. Before that, he had no relationships. So,
which infections who are, because of this STDs can cause splenomegaly?
HIV.
HIV. How does HIV cause splenomegaly? It causes splenomegaly. How can HIV cause splenomegaly?
It can lead to lymphomas. Or it can cause infection, it can lead to toxoplasmosis. But only 2 months history.
Tuberculosis, splenic abscesses, okay?
But ma'am, STDs okay.
Which other STD? Hepatitis B infection, viral chronic hepatitis can cause splenomegaly. I just asked you one simple question. Nothing. It is not related to this case. This case may be totally different, but these two things you should remember. Okay, go ahead.
Okay, ma'am. There's no significant past histories, drug allergy, no history of tuberculosis, seizures, diabetes mellitus, hypertension. Family history is not significant.
Okay. Is family history important in a case of splenomegaly?
Yes, ma'am.
Like what?
Conditions like thrombocytopenic purpura, thalassemia.
TTP. See, you all are confusing thalassemia, hemolytic anemias. Okay?
Yeah.
These are the two important. Thrombocytopenic purpura is a very, very rarely we see, and it doesn't come like this. Okay? It comes more with a central nervous system manifestations, convulsions. So don't say TTP. Okay? So for this, your history is over?
Yeah, ma'am.
So what do you think from the history? Does you have any other system involvement?
No, ma'am. No other systems are involved. Only there is pain in throat and for left upper quadrant pain.
Okay.
Abdominal discomfort.
So what do you think your first differential or provisional diagnosis you will like to give?
Infectious mononucleosis, ma'am.
Okay, you think it is infectious mononucleosis. Has this patient noticed any swelling anywhere else in the body?
He has not. No, he does not say he has. Yeah.
Why do I want to know that?
Because of lymphadenopathy.
Yeah, and those would
also if there is complications like Hodgkin's lymphoma, painless lymphadenopathy.
No, in infectious mononucleosis, it is usually tender lymphadenopathy. No, Hodgkin's lymphoma, it would be non-painless. It will be painless. Okay. Okay. So any patient coming with fever and some left hypochondriac pain, you assume it is splenomegaly. Like this patient has a classical history of upper respiratory tract infection, so it goes more in favor of infectious mononucleosis. But in case this patient would not have had URTI, what would have been your differential diagnosis?
With fever and splenomegaly, that's it?
Yeah. In our country, what is the first common thing that we want to rule out?
Hepatitis.
Tuberculosis. Malaria, Baba, don't
malaria.
forget. We were very eager to know that. And if you say malaria, your entire viva may go on malaria and it will be easier to score rather than saying tuberculosis. Okay, malaria. It has to be malaria. Any fever which is, anyway, this patient has continuous fever, but any patient coming with history of fever with chills and some pain in abdomen here and there, you must say first differential as malaria. If patient has history of fevers for a longer time, remittent fever, then your second differential should be typhoid fever. Okay? And suppose this patient is coming from Bihar, Uttar Pradesh or Odisha and he has got long standing, then it is Kala Azar, long standing lump. So basically when you have a patient presenting with with splenomegaly, if it is acute, you must remember differentials like malaria, typhoid, infective endocarditis and leukemias. And if it is chronic, it could be lymphoma, tropical splenomegaly, Kala Azar and portal hypertension. Do you think this patient has portal hypertension?
I don't think so. No, ma'am.
What means anyway, what history would have favored towards the diagnosis of portal hypertension?
Distension of abdomen or hematemesis or stools, bloody stools.
So basically, melena, hematemesis, and ascites. Okay. Can this patient not have ascites and still they have portal hypertension?
It can be possible, yes.
Like which condition? Where would be the obstruction then?
Where cannot
See,
have
some of the cases of extra hepatic portal hypertension, okay, where the liver is not involved and there is a thrombus in the portal vein, patient may not have ascites or may have very minimal ascites, and these patients have, what they have more is massive splenomegaly and they give history of bleeding. Okay?
Right.
Okay, so you think this is not a case of portal hypertension?
No, ma'am.
Go ahead. General examination.
The patient was examined in a well-lit room with due consent. The patient is conscious.
General examination.
Heart. Patient is conscious, oriented to time, place, and person. BMI is 21. Heart rate is 90 per minute. Pulse
BMI is low, right?
Hello.
Yes, continue.
Yeah. Ma'am, there is a lot of noise.
Yeah, I am trying.
Should I continue, ma'am?
Continue.
Felt in radial, carotid, femoral, or palate pedals, regular with adequate force, without any radial or radiofemoral delays, or and no apex pulse deficit present. Respiratory rate is 24 beats per minute. There's no cyanosis, clubbing, edema, pallor.
Do you know what is the relation of temperature and pulse rate with each 1 degree Fahrenheit rise in temperature? 10. Pulse rate increases by 10. Okay, 10. Good. Continue.
Lymphadenopathy is present on the right side. Posterior cervical lymph nodes are palpable, which are tender. Without there are no other places. There is no lymphadenopathy. Only posterior.
So when you talk about lymph node, whether they are tender, mobile, are they matted? They are not fixed to the surrounding tissues. You all are supposed to all that, and the size. Lymph node size, tender, non-tender, are they are they fixed to each other and fixed to the surrounding structure? So here you will say, how will you say this? Lymphadenopathy?
Non-matted 0.5 to 1 centimeter and not fixed to any other structure.
Okay.
Should I go ahead, ma'am?
Yeah.
Oral examination.
Now
Let's
wait,
perioral.
there is
Yeah, ma'am.
many other things you have to tell me. What about what is the significance of rash? If this patient doesn't have rash, but
No, ma'am.
but suppose this patient would have had rash, what clues it will give you to the diagnosis?
One, it can be either rubeola, or second, it can be typhoid, but it should be there in the
Now,
abdominal area.
Krishna, you are doing the same mistake. Rubella is not common in our country. Okay, so first is if it is malaria, you may say petechial rash due to low platelet count, then typhoid. That way you go. So typhoid, what type of rash you see?
Rosy spots are seen on the abdomen.
Rosy spots are seen. Okay, then so always say common things first. Then if it is infective endocarditis, you will see all other those rashes, Jannevis lesion,
Petechial, yeah, Jannevis lesion.
splinter hemorrhages, Osler, all those. Then which are the other chronic conditions which may come with splenomegaly and rash?
Common conditions.
Chronic conditions, commonly chronic.
Conditions.
Autoimmune disorders,
Felty syndrome,
SLE, rheumatoid arthritis.
SLE.
Yeah, patient may have rash and splenomegaly. Okay. What is Felty syndrome?
Felty syndrome is seen in rheumatoid arthritis. There is splenomegaly and pleural effusion.
And leukopenia. Leukopenia or thrombocytopenia. Okay. Okay. So if you are thinking of any autoimmune condition, you look for joint pain, deformities also. Sternal tenderness and bone pain. Have you looked?
So should I mention this in my examination?
Sternal tenderness you need to mention in general examination. Okay.
Okay, ma'am.
Yeah, sternal tenderness you need to mention in general examination. Okay.
It's only seen in.
Yeah.
Ma'am, it's only seen in rheumatoid arthritis. So.
Sternal tenderness, leukemia.
Okay.
Sternal tenderness is not seen in rheumatoid arthritis. It's seen in leukemias, blood cancers.
Okay.
Significance of
in every this hemat case, we have to talk about sternal tenderness.
No, I am just asking you.
Okay.
Like you can just mention. Usually, you get GIT case as a short case, but your viva may vary from here and there. We never ask same questions to the same candidate because the case is same. So we tend to ask many other questions related to the question. So I'm just making you aware that these questions will be asked. Mostly it is a short case, so you don't get to we don't expect you to present in detail, but at least when you're practicing, you should practice it properly. Okay.
Yeah, ma'am.
Now, what is the characteristics of the lymph nodes which are enlarged in Hodgkin's lymphoma or any lymphoma?
They are usually painless, rubbery. The size may increase or decrease in Hodgkin's lymphoma.
They are discrete and you can palpate them singly because they are not matted or they are not fused to each other. They are called discrete lymph nodes, discrete rubbery lymph nodes. Okay.
Yes, ma'am.
Okay. Suppose this patient would have had raised JVP. So what would it suggest?
Pericarditis or myocarditis?
No, it could be due to cardiac congestive cardiomegaly, which is causing congestive cardiac failure, which is causing splenomegaly. Okay.
Okay, ma'am.
Okay. What is congestive splenomegaly?
Congestive splenomegaly is usually caused either due to decreased amount of blood flow from the spleen.
No, basically congestive, there is a lot of pooling of blood in the spleen, right?
Yeah. but
So which
there
are
is due to decreased circulation, there is pooling of blood in the spleen.
So which conditions you will get lot of pooling of blood in the spleen?
Right heart failure, hepatic vein obstruction, portal. Yeah.
Portal hypertension, it is actually congestive splenomegaly. You are right.
Or splenic vein thrombosis. Yeah.
Okay. Now go to systemic examination.
Ma'am, oral examination.
In your general examination, this patient has only lymphadenopathy. No pallor also.
No pallor, no. No pallor,
no icterus.
Yeah. Ma'am, acute case of pharyngitis. So, okay, so should I say oral examination now or later, ma'am? Hello? 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 Hello?
Hello?
Hello? Yes, ma'am.
Continue.
On ma'am, oral examination, should I say right now or later?
Yeah, now you say oral.
Lips, perioral area, gums, teeth appear to be normal. There is congestion and soft pallor, anterior pillar and uvula. Posterior pillar is not seen. Pillars are not seen. No petechiae or rash or spots are noticed. There is grade 3 tonsillitis, exudative tonsils, follicular type. It is difficult to examine the posterior pharyngeal wall. However, it appears to be congested and edematous.
Okay.
Nasal examination is unremarkable.
Okay.
Systemic examination.
Mm-hmm.
The patient was examined in a well-lit room with due consent. The abdomen was exposed from xiphisternum to the pubic symphysis. Inspectory findings: abdomen appears to be symmetric, non-distended, no scars, sinuses, fistula, rash, dilated veins. The umbilicus is centrally lined. Percussion: dullness in left hypochondriac region up to 2 cm from the umbilicus and 4 cm from the costal margin. Palpation.
Palpation.
Palpation. The patient is febrile to touch without any and has no tenderness. There is splenomegaly up to 4 cm from costal margin towards the umbilicus.
Mm-hmm.
No pulsations are felt, and there is no other organomegaly.
That's it. You want to talk about spleen? When you talk about spleen, there are many things. Spleen size, shape, notch felt or not tender, moves with respiration. All that you are supposed to mention. Is there bruit over the spleen? Margin, whether it is soft, firm or hard spleen. So you describe spleen on those grounds.
Okay, ma'am.
So what kind of spleen?
Ma'am, the notch, the inferolateral notch in the spleen is felt.
First of all, it is 4 centimeter below costal margin, right?
Yeah, 4
is it soft, firm, hard?
It is firm.
It is firm. Okay, then?
There are no pulsations felt, and it is non-tender. It moves with respiration.
No, don't talk about pulsation. It moves well with respiration. Notch is felt. Okay. There is no bruit over the spleen.
Ma'am, bruit during auscultation, we would.
Yeah, okay, okay. You can say either here or during auscultation. That is also fine. So this is mild spleen or moderate spleen or a massive spleen?
This is moderate splenomegaly.
What is mild splenomegaly?
Mild is just palpable. It is 1 to 3 centimeters from the costal margin.
Do you mean see what is normal size of the spleen?
Normal size is
in anatomy you must have. It is normally
the largest dimension is 13 or 12 centimeters.
12. 8 by 8. 12. Largest dimension is 12 centimeter. Okay. Actually, when the spleen becomes palpable just below the costal margin, it has already enlarged twice. Okay.
Yeah.
But anyway, we will not be able to palpate. So if it is behind the rib, we usually we are able to palpate the spleen when it crosses the costal margin. Okay, and then we tend to say that it is so many centimeters below the costal margin. Okay, and moderate spleen is anywhere between 3 centimeter to 8 centimeter is called moderate splenomegaly, and massive splenomegaly is spleen
Greater than
which
8
is more than
centimeter beyond
8
umbilicus.
centimeter and which has crossed the or whatever. If it has crossed the umbilicus, it is always a massive splenomegaly. Okay?
Yes, ma'am.
How do you differentiate between spleen and kidney?
Ma'am, the inferolateral notch, kidney is ballotable, spleen is not. Movement with respiration is seen in spleen, not with kidney. You can get above the kidney, you can't get above the spleen.
Right. Notch is good.
Yeah.
And what are the other causes of lump in the left hypochondriac region?
Lump.
Which are the other swellings that you can get in left hypochondriac region? Not necessarily it will be always spleen, no?
Carcinoma from tail of pancreas or kidney.
Okay. It could be lump originating from kidney, pancreas, then stomach, then
any cyst that is present in the kidney.
Then any lump originating from splenic flexure of colon. All these will be palpated in the left hypochondriac region. Okay.
Yeah, ma'am.
What else you have got?
For palpation, ma'am.
What else? In GIT finding, what else this patient has?
Ma'am, percussion findings. Or should I start percussion findings, ma'am?
Yeah. Palpation is over, no? No tenderness, guarding rigidity, and splenomegaly is there, 4 centimeter, non-tender. Okay.
Firm, and there are no bruit present with no other organomegal.
Percussion, have you found? Is there any fluid or no?
In where? No. In ascites, no. There's no fluid.
Patient does not have. What are the causes of splenomegaly with ascites?
Portal hypertension.
And Budd-Chiari syndrome. Portal vein thrombosis, all those conditions. Okay.
Ma'am, will typhoid cause splenomegaly with ascites?
Typhoid will cause splenomegaly, but it will not cause ascites unless patient has perforated ulcer. No, there'll be ascites secondary to perforation of ulcer, and that is causing peritonitis, secondary bacterial infection. In that condition, patient may have ascites. Okay. Okay. What is your final diagnosis? Any other systems? Auscultation, you haven't found anything, no?
Auscultation, no, nothing.
Percussion?
No bruit. Percussion, yes. Dullness in left hypochondriac region up to 2 centimeter from the umbilicus, and dullness is present in probes space, and Castle sign is positive.
Okay.
The systemic examination is normal, ma'am.
Here, which other important system you want to examine?
Cardiac system I want to examine.
Because infective endocarditis can come. Okay.
Yeah, and
soft spleen.
Sorry, ma'am.
Causes of soft spleen. Spleen is very soft.
Typhoid
and infective endo. In malaria, you get firm spleen. These two are the again causes of tender splenomegaly: typhoid fever and infective endocarditis. Okay, there you get a soft spleen, and spleen is tender. Otherwise, all other conditions you will get non-tender splenomegaly. Okay. Okay. What is your diagnosis?
Ma'am, the case is of infectious mononucleosis with moderate splenomegaly and grade 3 tonsillitis without any complications like myocarditis, pericarditis, or involvement of neurological system.
Like which? What is the diagnostic test for infectious mononucleosis?
Monospot test.
Paul Bunel test.
Paul Bunel antibodies. Yeah.
What are neurological complications of infectious mononucleosis?
It can lead to meningoencephalitis, can cause CNS lymphomas, can lead to transverse myelitis. That's all I can remember. Hello. 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 Hello.
Hello.
Hello.
What investigations you will do?
Ma'am, CBC, ESR, blood smear, ASO
Okay,
titer.
let's start
pharyngeal
from
swab.
hemoglobin. Case of
Yes.
splenomegaly. Why hemoglobin is so important?
Ma'am, hemolytic anemias.
Okay.
Malaria.
So in hemolytic anemias, hemoglobin will be low. In malaria also, hemoglobin will be low. Lymphoma, leukemia, all these conditions, hemoglobin will be high. Okay, hemoglobin will be low. But if hemoglobin is high, okay. So which condition where hemoglobin is high and patient will have splenomegaly?
Polycythemia vera.
Yes. So you can have a polycythemia. And what complication of polycythemia vera may again cause congestive splenomegaly? It may cause thrombosis, either maybe portal vein thrombosis or hepatic vein thrombosis. And patient may have ascites and portal hypertension. Okay, polycythemia per se also causes splenomegaly, but polycythemia may cause portal hypertension due to thrombosis and patient may have splenomegaly. Okay, what is the importance of CBC? CBC examination in a case of splenomegaly?
Ma'am, it is very important because we can differentiate if it's an infection or it's a malignancy or if the marrow is involved. So it is important for further diagnosis if we want to do a tap.
I will say patient has leukopenia. What does it suggest? Low WBC count. Like in infectious mononucleosis, it will be leukopenia, not leukocytosis. Okay. Viral infections usually have leukopenia. Plus, which other conditions? Acute myeloid leukemia.
Marrow, Kala Azar and Salmonella, typhoid infection. Hello.
Hello.
Hello. Hello.
What is the importance of peripheral smear examination in a case of splenomegaly?
Parasite now.
Okay, malarial parasite then.
Even leishmaniasis.
Leishmaniasis, where do you look for which sample is collected for LD bodies? Either bone marrow aspiration, splenic aspiration, lymph node aspiration. Okay, splenic aspirate or liver biopsy. Splenic aspirate gives more yield of LD bodies, but it would be quite. It's an invasive procedure. We don't do it normally. Bone marrow aspiration is done common. So smear MP malarial parasites. Okay, then what else? Peripheral smear examination, you may see myeloblast, lymphoblast if it is a case of leukemia. Okay, if it is autoimmune hemolytic anemia, you will see cystocytes. Okay, you will see cystocytes in hemolytic anemia. Autoimmune hemolytic anemia, you see spirocytes. Hereditary spirocytes per se also will give rise to spirocytes in the peripheral smears. Okay. Hello.
Yes, ma'am.
So there is
Hello.
a lot of importance of peripheral smear examination. You look for the RBC morphology, whether they are sickle cells. Sickle and cell anemia doesn't cause splenomegaly, but if it is sickle cell with thalassemia, yes. What are the types of RBCs you get in thalassemia?
Teardrop. No, sorry. Target cells.
Yes, you get target cells in thalassemia. Spirocytosis, you get spirocytes. You get spirocytes in autoimmune hemolytic anemia also. You get cystocytes in hemolytic anemias. Okay. Then you may see those myeloblasts, lymphoblasts if it is a case of leukemia. If it is a post-splenectomy case, what do you see in peripheral smear?
Howell Jolly bodies, Heinz bodies,
and target cells. If it patient has undergone splenectomy, you will see, because these cells are not cleared by spleen. That is why you will see these things. Okay, so that is about peripheral smear examination. What are the other additional tests you will like to do?
Ma'am, I would like to get a pharyngeal swab and ASO titer as well.
Yes, okay. Then what else?
Ma'am, radiologically, I would like to do a USG scan.
Viral infections, you will like to rule out HIV, HBsAg, HCV also. Okay.
Yes, ma'am. HB.
What about USG abdomen? Want to do or no?
Yes, ma'am. So I would like to do a USG abdomen.
What additional information USG will give you?
It will also give information about the different organs, like the liver, in case it is involved, and also the condition of the spleen, the exact size of the spleen, and the kidneys, because we were confused between if it was
from splenomegaly, you may get additional information. Is there any splenic abscess? Which there are two infections which may make spleen prone to splenic abscess. One is typhoid, second is infective endocarditis. In HIV, you get multiple abscesses. They are either due to MAC infection or due to tuberculosis. They are usually non-tender, but you will additionally, whether there is portal vein thrombosis, whether the patient has ascites, whether there is any hepatomegaly or not. So there is obviously USG abdomen will give you lot of information. Plus it will give you an idea about portal vein diameter. Normally how much it is? 15 millimeters. More than that means portal vein is dilated. Okay. If you are thinking of what other tests you will try to like to carry out, you are still not getting any diagnosis. So far you have done so many investigation, patient has splenomegaly, and you are not getting any clue towards the diagnosis. Then
a Coombs test.
Okay, Coombs test is important. It will tell you whether it is hemolytic anemia, but that is also normal. The last resort in a case of splenomegaly is obviously bone marrow examination.
Right.
Bone marrow examination. Okay. So that has to be done to rule out whether there is any leukemia, lymphoma, or any myeloproliferative disorder. Okay.
Ma'am, is there any need of lymph node biopsy? Because
see here we would not do, yes, but if the patient has lymph node, yes, lymph node biopsy should be done before bone marrow examination. Okay, so lymph node, if the patient has lymph node biopsy is must. Okay. So
and
what are
chest X-ray.
What did you say?
Chest X-ray.
And chest X-ray. Yeah, that comes in routine examination. See, basically, and what are the causes of splenic rupture?
Splenic rupture can be because of sickle sequestration.
No, not in this case. I am in general asking you. Which are the conditions which make spleen prone to rupture?
Trauma, direct trauma to the spleen.
Yeah, one is blunt trauma. Second, splenic abscess if it is there.
Sorry, ma'am.
Splenic abscess due to bacterial infection. Yeah, it may make spleen vulnerable to rupture. It's a medical emergency basically. Anybody coming with splenic rupture, splenectomy has to be done. What is hypersplenism?
When the activity of the spleen has increased, regardless of the fact
what are the criteria? If I ask you 1, 2, 3, tell me those criteria.
I'm sorry, ma'am. No, I don't.
See, for hypersplenism, patient has to have a splenomegaly, first of all. Okay? There has to be at least 2 cell lines have to be depressed, like either it could be WBC or platelet or low hemoglobin. Okay? And bone marrow examination should be absolutely normal or hypercellular marrow. Means it is not basically marrow which is causing low WBC or low platelet count. So marrow examination has to be normal. So these are the 3 criteria to diagnose hypersplenism. And if patient has hypersplenism, what is the treatment? Again, splenectomy. Patient will not improve. Yeah. So all these cases, portal hypertension with splenomegaly, if we don't treat them on time, this splenomegaly is going to cause hypersplenism and patient is going to have complications like very low platelet, very low WBC, and then these patients are prone to more and more infections. Okay? Okay. So yes, I will stop here, but there are many other things your Viva may go on. I am just giving you clue and additional questions you must read about it. Massive splenomegaly, if it is there, you must know everything about Kala Azar, chronic myeloid leukemia, chronic lymphatic leukemia, how to diagnose them. Okay, so whatever we discuss, peripheral smear, bone marrow examination, all that you will have to tell the examiner. You must know everything about malaria apart from the diagnosis, treatment. So basically, whenever you have a case of splenomegaly, you must know about portal hypertension, you must know about lymphoma, leukemias, their treatment and diagnostic approach. Okay. Kala Azar case, although we are not seeing Kala Azar so commonly, but some of the examiners who have come from UP and Bihar, they may want you to talk about Kala Azar or they may ask you more questions about Kala Azar. Basically, it is only how to diagnose Kala Azar. And what is the treatment of Kala Azar, Krishna?
DC, ma'am.
Sodium antimony gluconate, no? Amphotericin B and miltefosine. These are the three drugs which we are using nowadays. Miltefosine. Other 2 are old drugs. And Kala Azar, what skin changes Kala Azar causes? That is why it is called Kala Azar, no? Black fever. It causes pigmentation of the skin. Okay? So blackish discoloration of the skin. So, okay, so far so good. Only thing, today you presented a very specific case about infectious mononucleosis. Normally we don't see so commonly. I remember I had seen this case during my residency. Patient had Epstein-Barr virus infection and that patient had cerebellitis. ataxia. After that, I have not seen. But otherwise, splenomegaly, you must know everything about portal hypertension, intrahepatic, extrahepatic causes, their treatment. I think last case we discussed treatment, management of portal hypertension. So today I have not asked you questions on that. But these are the different things you all need to know. Okay, any questions? Hello?
No, ma'am.
Hello? Any questions? Tanmay, any questions?
No, ma'am. Just a second. Hello? Hello? Yes,
Hi.
ma'am, I was just checking chats if anyone has any questions.
Yeah, yeah.
Ma'am, as of now, there are no questions. Can we wait for just a minute if anyone has any questions? Can we take them? Do you have time for that?
Yeah, 5 minutes I have.
Ma'am, is it okay if anyone who is having doubt, they can raise their hand? So, okay. Ma'am, Pushkar has a doubt. Why do we have a soft spleen and a firm spleen?
Basically, if the infection is acute, bacterial infections causes soft spleen, and baki malarial and viral infections causes, basically more inflamed skin will be soft because of hyperemia, while less inflamed skin will be firm. It is like that. Hello?
Hello? Yes, ma'am. Thank you.
Yeah, more inflamed skin, more inflammation is seen usually in bacterial infections, so that is usually soft.